Good afternoon, everybody. Dr. Nicolas Elian is our speaker today. Dr. Nicolas Elian is President and CEO of Vizstara. It's an educational center in New Jersey. Dr. Elian's clinical practice focuses on advanced bone augmentations and complication management. He completed his DDS degree and postgraduate studies in prosthodontics and implant dentistry at New York College of Dentistry. Dr. Elian was head of the Division of Implant Dentistry and Program Director and Director of Experimental Research at New York University College of Dentistry for over 10 years. I know him much longer than that, so I will not tell you how old we are. As a key opinion leader, he serves on the editorial boards of many peer-reviewed journals, and he trained an extraordinary number of specialists and general dentists in the science and surgery of implants. His topic today is Alveolar Ridge Management. I am not only proud and happy, I will follow your lecture, and if you have any questions, please put it in the Q&A on the site. And of course, at the end of the lecture, if you wish, I will manage the questions for you. So we look forward to a fantastic presentation, Nick. It's a big pleasure for me to introduce you. So the audience is yours.
Thank you, Adi. Thank you so much for your continuous support. You and Ken and Betty and Tara and the entire ICOI team. It is a tremendous honor for me and the entire group here at Vizstara to be part of the ICOI organization. And as always, thank you for giving me the opportunity to participate in the ICOI events. Good afternoon, good evening, good morning to everyone. Thank you for taking time to participate as well. As Dr. Palti mentioned, the topic for this next hour is alveolar ridge management from extraction socket to guided bone regeneration. Well, I'm coming here to you today from our center that Adi mentioned. I decided to come here because that's where I do all of this work and share with everyone some of the things that we are doing. But the truth is I cannot possibly do it by myself because I'm only one person. We do what we do and we do it well thanks to people like Adi and many others that you're seeing on your screen. And we have two additional people on our team that it is my fault that you don't see their pictures and their names. They're Nilo Hernandez from Florida and John Poovey from Colorado. They're the two newest additions to our team. And the goal here is to always augment the education and to help our colleagues really bring in new ideas and new techniques to their practices and to their patients. So it's thanks to this group and Adi, special thanks to you for being part of our team and organization. And what is it that we do here? We focus tremendously on training in implant dentistry and orthodontics, whether it is surgical prosthetics from level 1 to advanced and most complex. And our model, the model that we create, my wife and I, Martha Mikeo, is what we call hands-on practice-based clinical training. So at the end of the day, you as a dentist, you sit in the chair and you do the work and you treat your patient as if it was your office, because we believe that's the ultimate opportunity to enhance your skill set. You're seeing down here in the lower left corner of the screen, David Kim, another key member of our team, and many of the participants that we've had over the years. These are some of the graduates. They all become members of ICOI as they enroll in the mentorship program, and is a tremendous benefit for them. and ultimately they go through fellowship, mastership, and diplomats. And they've all seen how that opportunity is important for their practices and their lives ultimately. So to get into our topic, the challenge is always, can I get one implant, as you can see on the left side, and it looks reasonably well in the frame of the anterior teeth. Soft tissue looks good, the tooth looks good, or two implants, as you can see in the case of the two central incisors in the middle. But of course, we all know, and I think I hope our audience are very well aware of this, that you choose the right cases to showcase what you do. But I'll tell you, I also see cases that, as you can see on the far right, that come to our practice, and I tell the patient, I don't know what to do, because I don't have the skill set to regenerate that defect. And ultimately also I tell them that I think the operator did fairly well probably with what they had to work with. But then I see cases like this where I think we really have to change our thinking. And we really have to make the patients our partners in the case, to understand the limitations that we work with and their role that they have to play in order to get us there. So if I take a look at this patient and we wonder why we had so much bone loss, I mean, there are many factors. As you saw in the previous image, he had a lot of plaque accumulation and maybe not the greatest hygiene. In this image, you can see that he was going through orthodontic treatment. And we're not really sure where this case is really going. But ultimately, for you and I, if we took these teeth out, what are the options that this patient has? You know, I hear a lot about bone reduction guides, and maybe it's not a new concept because I am guilty of it early on in my career. I reduced bone like this type of case to get to a spot where I can place implants. But I realized later on, as I've really learned from my own mistakes and unfortunately others, that maybe that is not the right approach. Why should we reduce that bone? Maybe the ability that we have today and the fact that we've learned a lot more, maybe we can regenerate that site and have a better profile, have a better outcome. Because my concern in the other way around, if we go back one more time to this previous image, when we reduce bone by 5, 6, 7, and more millimeters, especially in the mandible or the maxilla for that matter, we're very close to the floor of the mouth, to the floor of the nose. And if there is a secondary event for that patient, will we have the same opportunity to treat that patient? So pretty much I kind of walk around all day long and say, okay, what is that formula for success? How can I be predictable? And then we all realize that there are many factors that allow us to be successful or not successful. So whatever these factors are, we have to think as follows. So when I'm successful, I would like to think I'm a great clinician, but also I understand that there's a patient, there's a good site that allows me to do well. There are some amazing products, and hopefully that I understand the science. But also, unfortunately, we all fail at one point. And when there is failure, I don't want to think that I'm not as good of a clinician, but maybe the patient or the site. When I talk about the patient, forget the mouth and the teeth. We really have to put a tremendous focus on medicine. What is their overall health like? What is that lifestyle that we are dealing with? And of course, then we get to the site and the product and the science. But I don't want to think just it is a tooth and a bone, because the patient is attached to an entire body. And there are areas that maybe we really should refocus our thinking to really better understand the influence of medicine on dentistry and how we can really integrate it into our daily practices. So what I would like to do is the following. What I call the clinical decision making. How can I avoid complications? Well, obviously, we have to talk about extraction socket preservation. We'll talk about immediate implant placement, guided bone regeneration, and a topic that is very dear to my heart, that also I talk about every day, is critical forward thinking. Because if we are not critical about what we are doing or how we're doing it, we might miss tremendous opportunities. And hopefully, if the time allows, we'll share some conclusions. So how do I avoid complication, and what is our clinical decision making? So I see this patient, and of course, I'm a dentist like all of you, my colleagues and my friends. We're all excited. I want to look to see what he has in his mouth. But it's probably a lot more important that I look at his face and look at his body and understand his medical history. Ultimately, yes, I have to look into his mouth, right? And I look and I'm saying to myself, okay, he has implants and he has teeth, like every patient that you and I, we see. But I'm more interested in the decision-making that the clinician went through. How did the clinician decide to save 2 teeth, place 4 or 5 implants, ultimately come back and add more implants? So that's how I'm seeing this patient. I'm saying to myself, okay, maybe the dentist had a real decision tree that went through and made all of these decisions. And when I look at the map, yes, on one side I have 3 good teeth. On the other side, I have a tooth. I'm not 100% that it is great, but it does not necessarily mean that it is bad. But this entire arch is treated in segments and multiple times with true lack of vision. I don't believe that the clinician had a real thought process on how to do this. And ultimately, when I look in his mouth, just like we saw from his facial profile and pictures, he is a severe class 3. And look what we are trying to do. We are trying to advance his teeth to make him look like he was a class 1. And maybe that is not the right thing. It might work for sometimes, but it may not work for a long time. And we look at the details of the case, we realize that the patient just finished, but starting to already have some problems. And then, when I look and examine him clinically, I see an implant that is somewhere very close to the palate, or more palatal, if you want to call it. And then I said to myself, okay, obviously we did not have a thought process to really address this arch, because obviously he has too many implants and he's unhappy, because if he was, why would he come to me at this point for treatment? A second case, the patient comes to me to retreat 2 maxillary central incisors. Yes, of course, you and I, we can look and there's a lot of other things that might be happening. But here's the treatment. It is done by the same operator, the same surgeon, and the same restorative dentist. So I wonder why for one site I select this type of implant and I select a different implant for the other site. And what was my understanding of the patient's hard and soft tissue? What was my understanding of that environment that I'm working with? And then I say, maybe I'm not that logical in my treatment, right? And I look at the adjacent teeth, and also they have problems as well. And another case that truthfully comes from the same group into my practice, and I'm looking at these implants and I'm saying, like, yeah, I only have one treatment option for this case, because I take the implants out and start all over again. But we must make the right decisions. How do I take these implants out? What should I tell the patient they can expect? Can I confidently tell them that I can regenerate that entire complex and bring it back to look like the other teeth on the other side, like 9 and 10? And I know there are a lot of people that they've put tremendous focus on the soft tissue, the papilla, all of that stuff. I can tell you, this patient does not need a papilla. This patient needs good implant therapy. So it may not be what you might be looking for from me or what you're expecting. I used to focus a lot on that, like, can I make the right side of the patient look exactly like the left side? I can tell you, after 25 years of doing this, when I look at this case, the very first thing I tell the patient, I can never make you look like the other side. So at the end, if anyone that really has some guidance on this, I would really appreciate it, because I also don't know anybody that can predictably do this very well. And finally, I see this case that also comes to my practice. Is a young 16-year-old girl. The photography is not mine, so somebody sent me the pictures to see if I'm interested in the case. So I collect the information, I look at it. Obviously, she just finished orthodontic treatment, congenitally missing 2 teeth and 2 lateral incisors, and somebody already placed implants. And I'm asked if I could restore it. And the truth is, I said, no, I don't really know how to restore this type of case because it's very complicated. I'm not sure what to do with it. Finally, she is restored. Somebody took impressions. As you can see, they send me the pictures with the impression copings. And this is the outcome. And they come to me to ask me if I can really do something with this case. And the answer is nothing short from taking the implants out, because the severity of the defect is very high. I don't know how to treat just the 2 lateral incisors. I have to look at the entire maxillary anterior complex to treat that patient. And remember, she's only 16 years old. So the idea is, if you don't know where you are going, any road will get you there. So it is a very similar analogy to what we do with implant dentistry. If I really don't know what the final case is going to look like, well, I can place the implant anywhere. It should work, right? Unfortunately, from what we have seen, it doesn't work. And I hope that some of you, or hopefully many of you, will agree that we really have to start with a prosthetic concept. Where do the teeth belong? What do I need to do to ultimately get the patient to function? And my friends, I'm telling you, my focus is not to get them a papilla between 8 and 9, like the case that I showed, because I really don't have what it takes to get them that. So that gets me to change the way my thought process was, and to change some of the things that we have done in the past. Of course, we focused for many years on extraction socket preservation. Can I take a tooth out and preserve as much as I can? Maybe not 100%, but close to it, because it is an important event. We have to be able to preserve what we have if we can. So what is the thought process in assessing that site, whether I can preserve it or not? I must understand biotype. I have to understand the root length, width, and angulation in relationship to adjacent teeth. I have to understand whether I have a buccal plate or I don't. I also have to understand what socket that it is, and we'll come to that in a bit. I have to understand if there's pathology around that tooth or adjacent teeth. Doesn't necessarily have to be that tooth. Of course, you and I, we have to understand anatomy and critical anatomy, such as nerves. The sinus is a little bit more benign because we're all comfortable getting there and doing some work. We also have to understand ultimately the macro and micro implant design that we're working with. How do I design an abutment? Even at that early stage in socket preservation, we're not talking about immediate implant placement. And we also need to understand what that perioral muscle action can do. So we've all seen this. Before extraction, everything looks great. If we take the tooth out, we also have seen this work from Schrob and others, that eventually close to 50 or over 50% in some cases of bone loss. So how do we recompensate for that? Can we change that method and eliminate some of the guesswork? Can we preserve that complex of hard and soft tissue before we decide to take the tooth out? Do we know enough? Do we understand which socket will actually do very well? More importantly, which patient will do well? But it all depends on our level of knowledge, our skill set, and our ability to communicate also with our patients. We need to make them understand, and it's only communication. What are the limiting factors that they are presenting to us with? If they don't understand that they have limiting factors, then we're taking on that tremendous burden and responsibility that we're going to make them whole, and it may not be the case. So before we take a tooth out, we have to agree that there are 3 sources of blood supply to that socket: the periodontal ligament, the preosteum, and the bone marrow. So obviously, the minute we take the tooth out, we at least lost 1/3. And the reason I'm saying at least lost 1/3, we're hoping that they're equally divided, right? Because they may not be so well divided. And maybe for that particular socket, the ligament is the most important source for that area. Maybe we don't have enough marrow space, as you all see on many of the buccal plates, that we have very little marrow, if any, at times. So let's talk about what I call a simplified socket classification. And how do we fix it? It is a repair technique. It sounds like more mechanical, right? So type 1, where you have the entire soft tissue still intact, the buccal plate is intact. And you know what? Hopefully we see more of those because they're the most predictable ones. When we get to the type 2, the soft tissue looks almost intact or some loss, but the buccal plate, some of it is gone. And the type 3 that is more severe, where we have really no buccal plate, we lost a good volume of the soft tissue, and how that complexity comes into play. So how do I look at the socket? I want to understand the socket depth. I want to understand the relationship of the palatal bone to the free gingival margin, as well as the buccal bone, right? They're both equally important. Don't underestimate the value of the height of the palatal bone. I want to look at the relationship between the buccal crest and the palatal crest to the free gingival margin. We all know that the buccal crest is higher. And then I want to go inside, whether I started with a cone beam, right? I might see some information, but ultimately I'm already inside the mouth. I want to examine the integrity of that buccal plate. I want to see, does it have any fenestrations? Is it missing somewhere? What is going on with it? And of course, I have to understand its thickness. It is important. I need to look at the mesial and distal relationship of the crest of bone to the adjacent CEJ teeth, right? The adjacent CEJ of the teeth, because that also is going to play a factor in what I can get and what I don't get. I need to understand the buccal lingual dimension, because also if I tell the patient I'm placing bone here and that dimension, for instance, on a molar is 10 millimeters, obviously I cannot expect to go back in 2 months and I have completely filled socket, right? So I have to understand how long does it take for that socket to heal. And of course, equally important, I need to understand the mesodistal dimension, because the bone is going to come from all the walls, kind of all at the same time, and hopefully at the rate of 1 millimeter a month. So that gives me some ideas of what to tell the patient when I can predictably go back in and place an implant. So I need to look at this particular case, because it tells me a little bit about how that socket fills with blood. Because I need to understand the regenerative potential of that site. If I see it that is depleted and doesn't fill with blood, and I don't understand the pathology that I missed on the scan or on the PA, all of a sudden I see it clinically. So I have to be able to clean the socket, and determine all of these parameters that I mentioned to you before. So what is it that we're doing in this particular technique? We're assessing the socket in all the dimensions that we've discussed before. Ultimately, we have to take a tooth out, hopefully atraumatically, right? And we all have different definitions for that. Sometimes my definition of atraumatic sounds very traumatic, but ultimately you have to find a method to take the tooth out. There are many supportive tools outside, whether it is a technique or a special device that you can use to extract the tooth. At the end of the day, you need to take the tooth out, place a membrane if you are missing part of the buccal plate. And where to place that membrane, it almost sounds like a debate. It can be inside the socket or outside the socket, and I've done both. I can tell you today, my preference, it should really be outside the socket. So you identify where the defect is, you dissect it gently if you can, and place your membrane outside the socket, fill the area with bone, place a couple of sutures. And for me, one of the methods that I used to use, but thanks to Dr. Palti, that I've changed a little bit in this regard. So I used to always want something fixed, even if I had to stand on my head. Most of the time wasn't easy to do. But today there are alternatives to that, such as flexible partial, which you can avoid this, and you can avoid also immediate loading, and we'll talk about that a little bit as we go forward. Case 2 looks a little bit maybe simpler because the buccal plate here is intact. You take the teeth out, you fill your sockets with bone. You always must close the orifice. At least that's what I do. Some type of a membrane that you're comfortable with could be resorbable or non-resorbable. And ultimately, you have to let the patient leave with a provisional to protect the site. So again, early on in my career, everything was fixed. And thanks to Adi, lately he introduced me to some other techniques. So I'm using some in some cases, some removable flexible partials to allow me to achieve pretty much the same results. In the next area that we're working with today is we're talking about immediate implant placement. Is an area that I'm very interested in, and I've done quite a bit of work there. But the only reason that you see the articles cited over here, because at the end of the day, we're all of us, including every one of you sitting there, we're all focusing on what is that dimension of that buccal space on the implant? What is that thickness? What do I need to have there in order to make me successful? So, we all agree, you need at least 2 millimeters of buccal bone. Otherwise, you're really chasing yourself, and eventually you're dealing with recessions. And pretty much the literature is almost conclusive. Again, we're all saying the same thing. This is always about the thickness of the buccal plate, the size of the implant, the location of the implant, your technique of extraction. So they're all pretty much very, very similar techniques. And then ultimately, okay, how do we leave it, right? Do we leave it with the healing abutment, with bone, without bone? I can tell you, I've learned really the hard way many years ago. If you have a void and you don't fill it, it's gonna come back to haunt you. So for me, whether the gap is 1 millimeter, 1.5, or less than 1 millimeter, I'm closing every gap. And if I really have an opportunity and I have the right patient and the right environment, and hopefully I have the right skill set at that time, I'm temporizing the implant. But again, as I said, because of interacting with Adi very, very closely, I think, what? Why go that far? Maybe the patient can function with something reasonably comfortable and looks good without really taking all of these risks. But again, I'll share with you some of the stuff that we have done, and hopefully it gives you some hints or helpful tools for your practices. And for that, I decided to really share with you not what I do, or in one case, not my own work, show you the work of one of the participants over the years in the mentorship, Jerry Gonzalez, who's a dear friend, very dear friend of mine, and an amazing dentist and a tremendous talent. And by the way, he's on our faculty today. So take a look at this case. Jay is a restorative dentist. When he came to us, he had never placed one implant. But I knew he has what it takes to really go very far in this field. So we all know that this is a failing 3-unit bridge, a mesially tilted tooth, recurrent decay, possibly fractured tooth, limited soft tissue, big concavity on the buccal. So Jerry plans the case. He works very closely with David Kim, who's a key player on our faculty, and he's a meticulous treatment planner. So they look at the case, we figure out what to do with this case. Ultimately, you look at the scan, you decide where you want to place implants or not place implants, right? So we knew right away that site number 30 is the most limited or probably more challenging. But our approach to the case, or more importantly, Jay's approach to the case is, you know, can I potentially go and do an immediate on number 29? The answer is yes. In our environment is something that we're comfortable doing. And yes, you're gonna say we're cheating because tooth number 31 is not an immediate implant placement because we're going somewhere on the mesial side. And that's a fact too, right? But ultimately, we're going to get somewhere in the socket. And the idea is, how do we manage that entire space? So Jerry, yes, he did 29 as an immediate, 31, hopefully you'll accept what I'm telling you, it is on the mesial root because you can see on the crest that it is not in the healed site. And ultimately, he does an augmentation for tooth number 30 to enhance the soft tissue volume and enhance the entire soft tissue profile everywhere. As a matter of fact, in this image, you can see on the panoramic view that the implant, part of it is in the socket, right? And he restores the case as such. But look how we changed the entire environment in that site of hard and soft tissue, right? And he did incredibly well. We've eliminated the concavity. We provided better attached gingiva and keratinized gingiva around the implant. So I think he did it very well, and I'm very proud of the work that Jerry does. But that also leads me to tell you about one of the very early cases that I personally did. That was really way before cone-beam CT in a dental office. And it was in the days of the medical CT. And the challenge in those days early on in my career was whether the patient can afford my implant or they can afford the medical CT. So I did that case without a CT. I extracted a lateral incisor. As you can see, I'm trying to really find out where that buccal plate is, where the mesial crest of bone is, where the distal is. Long story short, I placed an implant and I decided to temporize it. Chair side with a very simple polycarbonate crown. But in those days, I thought it really has to be completely out of occlusion. You know, I also do a lot of restorative dentistry. And I kept trimming the tooth, and it's not gonna look like a tooth anymore. Eventually I stopped. Not because I knew what I was doing, but this case is in the mid-90s. So I was kind of dabbling and like selecting certain cases to do this on. As I moved forward and I've learned a little bit more or better understood what can be done and what can't be done. So I started to take cases that are a lot more challenging. So in this particular case, you see that I have a buccal fenestration. It's a compromised tooth. I took the tooth out. I placed an implant immediately. I grafted the buccal site. I did a lot of things that, you know, I thought in the past that I couldn't do, and ultimately temporized the patient as well. So she traveled from far. So Adi, I hear you about, you know, you don't want to take the risk nowadays when people can't travel. So maybe you need to give them something that is not immediately loaded. So a removable approach, hopefully with something that works really well as a flexible partial, could help us in this area. But maybe you would think I should be embarrassed showing you this stamp. Honestly, I'm not, because the temp was there for a long time. And yes, I know it's already beaten up after a year and a half. But what I'm happy about, or what I really want to show you, is the soft tissue complex that I was able to manage. And that's what we can hope for. So this patient initially had this diastema that I've created, or she told me that she had a diastema. Eventually, she wanted to close it. My wife does orthodontic treatment on her. I decide to temporize her. The temporary is not adequate. That's what I've received from the lab. I have many technicians that I love and I respect, and they're super talented. But you know what? We all sometimes make a mistake. So the provisional that I had wasn't adequate. The abutment isn't adequate. So I changed the abutment. So you and I have to decide to do this work, because the truth is, the technician's responsibility is from the free gingival margin up, and our responsibility from the free gingival margin to the head of the implant. So I decided to take that responsibility and decided to reshape this. But I still made another mistake. I over trimmed the temporary, but that's what the patient left with. So how often do we do this? I can tell you, probably rarely that I will take maxillary tooth in particular, or for that matter, any tooth in the mouth, and that I'm not putting an implant in. Again, the selection criteria is hopefully I have the right patient, the right medical profile, the right tooth profile, and all of these factors that have to work really in favor. So we're doing this quite often. We're doing it on molars. I do not do this technique on second molars because I really don't find that there is a need for it. And in most cases, we are really preserving or even enhancing that environment in some cases. We struggled with this concept for many years because of the work of Arujo and Lindy. And again, I tell everybody, the reason it didn't work very well based on the work that they did, because they really selected the wrong size of an implant. And of course, the dog model is a very thin biotype. So they really had two variables in the equation that they were negative, fighting against them. So we lived with that concept for many years. So some people think we can compensate for this with the socket shield. And we all know that for some people, it is a great technique. Regardless, it comes with easily close to 20% of complications. And we also, the evidence is not overwhelming. That's why we're all not doing it every single day in our practices. So you select some cases and you do it. The idea here is to show you not that the technique that we're using is the answer for all the problems that we have, but it is a technique that has been working for us. So really then, rather than the socket shield, we're compensating for that by grafting that buccal space very densely, and a method of temporization to prevent the muscles and the lips from invading that space. And it seems to work very well. We've been doing this for some time, and it seems to be a very predictable technique. We're working on this data for a long time, and I'm guilty of it, that it doesn't get done. So hopefully we'll get it done soon, and hopefully we can share it with you in the literature so you can see what we have done in that space. Now let's talk about guided bone regeneration, because remember, it is all about alveolar ridge management. How do I deal with that ridge? What do I need to do in it to allow me to have implants that are successful long term? I don't know what that is, right? But we'll talk about that. So the reason we need to manage the ridge is because we've all have dealt with ridge deformities. And there are many techniques in the literature, and I'm confident that all of you are using something that works incredibly well for you. You're using GBR, block grafts. I haven't done this. I haven't done a block graft probably now for almost 15 years or a little bit more. I do GBR a few times a week. And pretty much every day that I'm practicing and I'm placing implants, there's some type of a GBR. I haven't done distraction osteogenesis for more than 10 to 15 years as well. I do use a lot of short implants because I think they're predictable and they're a solution for some of the problems that we have. At one point, I used BMP2 and growth factors. I can tell you honestly, I have not also used BMP2 for probably 7, 8 years, not more than that. And guess what else I use and I continue to use? Pink porcelain. I think it is one of the greatest tools that our great ceramists can give us, and we can get out of the woods and on some of the cases. But how do I treat a rigid deformity today? I need to understand a few parameters that are important for me to get me to that success story. I need to understand the defect. You know, I am not an operator that can fix every defect. There are defects that I think I can do very well. And I'm pretty sure it is the case for many of you. My need for augmentation for some reason seems to continue to increase. So at one point I used to think I'm augmenting maybe 20% of the cases. Truthfully, I'll tell you today, probably more than 80% of the cases I'm doing some kind of an augmentation. And then I used to think that I need to regenerate what was lost. I've learned that what was lost is not enough around implants. I need to generate a lot more. So yes, I'm generating more bone if I can. So my technique also varied. I used to think maybe, okay, well, I need one membrane over that implant and that gets me there. So then I've learned that I need more than one membrane to create the scaffold, create more space to contain that graft and that defect, and to create what I call a watertight closure. So then, you know, the bone is not moving around, the area is not being compressed. Also, I used to think that I needed connective tissue or connective tissue alternatives once in a while. I can tell you every time I'm doing an augmentation, it comes automatically with soft tissue enhancement. As a restorative dentist, I've kind of trained myself anywhere, even in a pontic space. If I have a concavity in the arch, I like to repair it because I find that it is more cleansable, it works better for the patient. But the only reason I end up doing all of this stuff, because I've increased my knowledge. And that's when I really started to feel like I'm empowered to be able to do more of this stuff. So it's really all about knowledge. And of course, I have to build my skill set. You know, I have to learn new techniques. Again, I'm sure some of you in the audience I've interacted with in some way or another, just like I interact with Adi. So he says something, I say, oh, fantastic idea. You know, now I have new knowledge, and now I have to go take my skill to work around it. And I said, in terms of the ridge augmentation and regeneration, today I don't have the use for autogenous grafts. Some of you probably like it a lot. For me, I think it's I've compensated for that somehow. And if you look at this, it's not like we're doing it just for the sake of doing it. We want to understand histologically what we are getting. So for many of the cases in the past, we've done histology just to analyze exactly what we have and the percentage of new bone that we are getting. We're more, and I shouldn't say more, we're probably a lot more, a higher percentage of the bone that we use is bovine bone. We rarely have a way to go to an allograft. Once in a while, maybe a combination. And again, I think many of you have figured out these skills and these areas. I'm gonna skip through this literature just to share with you some of the cases and make sure that we're on time for the questions if you have any questions. This is a very old case that's when I used to use a lot of titanium mesh, because the truth is I didn't know how to create a scaffold early on in my career. So I thought the only thing that could allow me to do it is a titanium mesh. So I did a lot of work with titanium mesh, as you can see in this case, but you must protect it with some type of a membrane. resorbable or not, that's really your choice, but it must be protected. Otherwise, the invasion of the soft tissue into the graft is a huge, into the mesh. And, you know, over the years, I became efficient at it, so I can place a mesh, place a graft, and get in. And as you can see, I can take a site from 2 millimeters to 10 plus millimeters or more. As I said, you always need connective tissue or a connective tissue alternative. And as you can see, here's the case that I showed in the beginning. I knew from the beginning I was not going to create papillas for that patient, and I never claimed that I would. So I already told the patient that they're going to have pink porcelain. So I knew also, again, from early on in those days, that there are a lot of limitations in what we do. So that gets me to the second case. And when I was talking about define where that defect is on the buccal, that defect is on the crest. You need to go to good anatomical landmarks to allow you to be there. And as I said, rather than the mesh, now I'm using multiple membranes and I'm using the graft to create that scaffold and that environment. And I can close this, advance my flap, and ultimately go back in and regenerate that site to that level. So that's what I find that today the most useful procedure for me in guided bone regeneration. I do this pretty much on a very regular basis. I'm using it all the time. And we have a data that we compare the pre-op scan and the post-op scan to really measure the volume that we have regenerated. And as you can see in this particular case, where the defect was and where we have enhanced the volume of the soft tissue. This is the case that we started with in the beginning. So I'm gonna skip the maxilla because the mandible is more interesting and we'll finish on time. So I extracted these teeth as you saw in the beginning. I did an immediate implant placement, and these sockets, they're more of like a type 3 socket. I built bone, I scaffolded the bone with membranes, and then I added alloderm to enhance the soft tissue volume. To do all of this in one surgery. My friends, it doesn't have to be done this way. It is not every case that I'm doing like this. It is really case selection and me knowing that it is something that I can deliver successfully. But you can do it all in steps. You can place the implant and the bone, allow it to heal, come back and enhance the soft tissue profile. And that would work very well. And that's kind of what we have done in this case. And the restorative dentist here is Steve Hudis, and he's the one who did the restorative work, a prosthodontist in Princeton here in New Jersey, close to us. Adi, do we continue or we'll get to the questions now?
You can continue. Go ahead. Okay. You have time. Go ahead.
So the area that I think is important that for you and I to distinguish and I know Adi does quite a bit of this, guided bone regeneration is really, what you're really depending on is the space and the scaffold that you created, and hopefully you're getting some signals. In tissue engineering, we get cells to come into play, and that's where PRF and other supportive methods are very, very important and could be useful in what you do. So biological mediators and growth factors are important, but that really gets you more from guided bone regeneration per se, and now you have a tissue engineering head. So in all of these, the factors that you can control, the space and space maintenance, the scaffolding, the containment and what you do, the tension-free closure, believe me, is not very complicated. Anyone eventually ultimately can learn it by practicing and building your skill set, taking a simple case and advance it and take it up a notch every time, up a notch, and it will work. And you have to maintain it closed. It's not enough that I close the day of surgery. And time, unfortunately, is a volume dependent. So if I'm building 7, 8 millimeters, it's going to take at least 7, 8 months or more. The factors that you and we don't control is the patient, the medical history, and the dental history, the environment that we're working with. and the ridge or the site classification. You have to pick a site that has really good regenerative potential, because that's what will make you shine and be successful. The selection of the graft material is really, the science is there for both sides, for all sides, for the autologous, for the allograft, for the xenograft, and even for things like BMP2 and others. Really, at the end of the day, is you really have to look yourself in the eyes, in the mirror, and say, I am capable of doing this, and this is what I use. So this is some BMP2 work that we did in the past for full arch severe resorption. We did well with it. Again, as I said, I figured out how to compensate for it with other technique. So what is really critical forward thinking in this concept of implant dentistry? You really have to understand, as a clinician, anatomy, physiology. Of course, I know all of us here spending time on a Saturday afternoon, we all know the anatomy very well of the environment that we're working with. We must understand the physiology. Although I think I understand it, but sometimes I might overlook it. We need to examine the patients, their muscles, their strength, how they influence what we are doing. We really have no choice but to understand medicine. What we are doing is not independent from the body. So we really have to understand medication, medical history, health, and overall health in order to be successful. Biotype, age, forces, orthodontics, restorative, and the pressure that we put on these sites, whether we can really allow that site to regenerate or not. And we also must understand that our implant is never a replacement for a tooth. So I'm never going to tell the patient, you know, your implant is going to be better than your tooth. I'm hoping that we'll give them something that looks really good, allow them great function, allow them to smile and be happy. But at the end of the day, it is a device, it's not an organ. It's never going to perform like your tooth. I haven't seen it happen yet. I'm not sure that it will. So our treatment planning really has to kind of be slightly reversed. Most of the time, we're looking at prosthetic requirement and surgical convenience to get us there. I really spent a lot more time today on understanding the biological cost. The biological cost, really, medicine in it, why I'm not successful, and how I can be very predictably successful and deliver the results. So it is not hardware and surgical convenience, right? And I'm wondering which one is current and which one is an old technique. There is no old technique here. Biology is biology all the time. And when I find that I miss it, that's when I'm really stuck. And I find that regardless of the surgery that I did, if I'm stuck in a restorative event or a prosthetic event, then the patient is stuck with me and I don't know how to get out of that. So really we have to focus about biology. So my ideas is to really replace concepts and beliefs, not because, you know, we did it for the last 50 years and we continue doing it. We should think differently. Our primary goal should be to really reduce morbidity and the treatment time. We need to get our patients efficiently done, not just because I want to build bone and I want to wait a year to do it. And we really, I think we're all doing it in different ways, redefine our knowledge and creating new standards. I think we're all doing this. That's why we're here on a Saturday afternoon. So we take cases that look like this, and I don't want to wait 2 years to deliver this case. With proper treatment planning, and Adi always teases me, I'm not a digital guy, but I have a lot of digital support. So I have Chris here, I have David, I have a new member on the team, Aziz. So that's the digital team. So I come to the chair and I do the work and I get all the credit. But really the credit is to all of these guys that they're doing the work behind the scenes. So I can take a patient that looks like this, take the teeth out, do immediate loading, deliver the case, and ultimately somebody goes to work on the restorative. This is Mary Beth McCabe, also a restorative dentist that was part of the mentorship and did this kind kind of work, but I'm always thinking of the life of your case. The life of your case is the life of the patient, and you have to be prepared and ready for the changes that you're faced with, because if we're not, we're really stuck. We're gonna come to spots where we don't know what to do. And finally, I really want you to pay special attention to this particular animation. It's Chris's work, who is an incredible illustrator and animator. And I always see him, I said, Chris, if one day I'm really sick, you probably can do my work, because he really understands in depth the science. He knows the anatomy very well. He built these muscles one by one. And my goal here is to show you that if you are missing teeth, and that's the detriment. Missing teeth is a handicap. It's like, unfortunately, somebody missing a leg or a finger or an arm, right? It is not likely. So how it impacts that function. And you can see how the lip starts to come into place and actually resorb the bone. That's what I want that you and I to hopefully avoid and prevent from doing. And look at this particular patient. Is a live illustration of what the diagram is. You know, I tried to do a lot of augmentation on this patient. Unfortunately, I was never successful. It is the maxillary right side. Every time I augmented him, he came back, I didn't have bone. Early on, I didn't understand why. And now I really understand a lot better. If you look inside, as he moves his mandible, where actually the coronary process is coming to invade the area that I was trying to augment in the posterior maxilla. And the truth is, I end up not being able to graft him. So I placed 2 short implants on him. So if you look deep into nature, you really understand things a lot better. So we're looking at the teeth and we're missing that entire environment around it. The face, the lips, the cheeks, the tongue, the swallowing mechanism, patient's habits, and of course, the rest of their body and how it is attached and influencing what we are doing. With this, I want to thank you all. Adi, I want to thank you for the opportunity that you gave me, and really look forward to seeing you soon in New Jersey.
Thank you so much for a wonderful presentation, and you brought a lot of practical points to the table. And I know you are an excellent clinician, a fantastic speaker. So we have 3 questions here. So maybe you can address it. I will. You see the Q&A?
Yes.
Or
yes.
Okay. So click on the Q&A and answer the questions, and if you need anything.
Okay. Do you use stacks or screws? What is your go-to method for vertical versus horizontal ridge augmentation? Do you ever use DPTFE cytoplast, titanium reinforced membrane, or just alloderm and or collagen resorbable membrane only? Does anatomical site matters in terms of technique for GBR chosen? David, thank you very much for your question. I think it is a great question. Very often I have to use stacks because I cannot keep the membrane in the position that I want to. So it is very, very important for me. I don't use tenting screws because early on, maybe because I didn't know how, I had a few mishaps of the tenting screw going through the soft tissue. So I compensated for that. The method for vertical augmentation is really a PTFE cytoplast type of non-resorbable membrane reinforced with titanium, right? So if it's well designed and you can manage it and keep it and protect it, I think that's what gets you there. For the horizontal type of augmentation, primarily resorbable membrane. If I have a situation where I find that the muscle action is too strong, then what I'm doing is actually going to a non-resorbable membrane, such as BioGuide, Biomend Extend, whatever you're really comfortable with and you can use. The next question, Adi. Do you use a pre-treatment checklist before treatment planning? The answer is yes, but you have to have a checklist. As I said, this is really understanding the defect or whatever it is that you're doing. Treatment planning is a very broad concept. So let's say treatment planning for an extraction socket and socket preservation. Yes, of course, I have to understand what is it that I'm taking out, right? What type of socket it is. I have to understand the patient's medical history. I have to understand how I'm going to temporize it. So all of that is part of treatment planning. Adi, I think I answered.
You answered fantastic all the questions. And just a word about if you ever use the Curie technique or things like that. Well, for David, well, I'm using different techniques, yes. I use the Curie technique, but what Nick showed this evening, which I appreciate very much, is that everybody has to start somewhere and find a predictable, 100% evidence-based proof method. The Curie technique is a very delicate technique. You need years of experience, you need a lot of skills, and you need a lot of luck. So I think that if you want to do predictable augmentation and reach vertical and lateral, personally, and I'm not 25 years, I'm 40 years in the implant field, so a little bit longer than me. So I think that people should start with techniques which you can control, and don't forget that one of the most important points in our profession, as Nick mentioned, is troubleshooting. So what do you do when you lose those bone plates and the screws and everything else? So just think about it. It's a good method, no doubt, but it's combined with a lot of experience, a lot of talent, and luck. Just to answer this question, because I don't want to leave people in the dark. So Nick, thank you very much. You will see this this lecture on our YouTube channel, ICOI Dental, and I look forward to see you in 2 weeks at our next webinar.